Good afternoon, everyone, and welcome to the COVID-19 Delta variant and vaccination webinar. My name is Molly Howell, and I'm the Immunization Director for the North Dakota Department of Health. And we are hosting this webinar today because we've been receiving a lot of questions about COVID-19, but specifically about the Delta variant. North Dakota has identified 25 cases that have been confirmed to be the Delta variant, which is an increase over previous weeks. We expect to have another increase tomorrow in the Delta variant when we look at the laboratory data. And just as a reminder, when we say 25 cases of the Delta variant, that may seem low. That's because not every individual who tests positive for COVID do we do that whole genome sequencing on to understand what variant they may have. It's just a small sample. And so we more look at what percent of our variant cases are Delta, and Delta is increasing more than any other variant. Also, for our region of the United States, the Delta variant is the predominant variant. And so it is very likely that in North Dakota, Delta is the predominant variant in our state. We have seen increases in cases over the past week. Right now in North Dakota, we have 292 active cases. The majority of our cases are in the 20 to 40-year-old age group. That is a low number of cases when you think back to our peak last November and December, but we're more concerned with the trend. We're seeing an upward trend in cases. Also, our hospitalizations have doubled in the past week. We currently have 20 individuals hospitalized. In the past week, though, we've had 38 individuals hospitalized, and 8 of those individuals are between the ages of 20 and 40. So we are seeing more severe cases in younger age groups. And so we wanted to have this webinar today to inform people about the Delta variant and about vaccine effectiveness so you can make a better decision regarding whether or not to be vaccinated. We're lucky enough today to have Dr. Paul Carson presenting. He is an infectious disease physician and professor of practice in the NDSU Department of Public Health. He has over 25 years of experience in various clinical capacities, and he works with the Department of Health on a number of projects related to immunizations and infectious diseases, including healthcare-associated infections, antimicrobial stewardship, and vaccine education. Dr. Carson does not have any funding to disclose today. He does not accept funding from pharmaceutical companies or vaccine manufacturers. And so I will turn it over to Dr. Carson so we can all learn more about the Delta variant and vaccination.
Thank you, Molly. Good afternoon, everyone. Pleasure to be with you. As Molly noted, the health department and I myself have received a lot of questions about what does the Delta variant mean for us? Does it change things? What might we expect? And as many of you probably have seen, information tends to come fast and furious with lots of new data kind of pouring in all the time. So I'll try and walk through that with you today and help make some sense of that. So what are these variants of concerns versus variants of interest? So just as a sort of background, when viruses replicate themselves, they can be sort of really good at it, or they can be kind of sloppy at it. And sometimes they make very exacting copies of themselves, and sometimes they make little mistakes or mutations that are not exact copies of themselves. When they make some of these mutations or changes or inexact copies, sometimes, most of the time, that's not advantageous to the virus. It doesn't help it, but occasionally one of those changes may be advantageous and help it spread further, or it might enable it to cause more serious disease. Variants of interest are just noted variants that have one or more of these changes. Variants of concern are those variants that have some evidence of either greater transmissibility or contagiousness, or greater ability to either escape our immune system from prior infection or vaccines, or greater ability to cause more severe disease. And our focus right now is on Delta. We've seen, Alpha, which was originally out of the UK, Beta originally out of South Africa, and Gamma originally out of Brazil. Delta variant, otherwise known as B.1.617.2, emerged first recognized out of India and has become now probably the dominant strain around most of the world. So what do we know about Delta? As the World Health Organization calls it now, they describe it as the fastest and the fittest. It seems to be able to outcompete all of the prior variants wherever it emerges. And we know that the Alpha variant, which again emerged first recognized in the UK, rapidly replaced the original strain, which was first identified out of Wuhan, China. That variant was significantly more contagious than the original strain, about 43, and some estimates as high as 90%, or almost double the contagiousness of the original strain. Delta has now been compared to that Alpha variant and is about 65% more contagious when we look at it in a very good setting to study this sort of thing, which is like households where an index case comes in and how many household contacts end up getting infected. And it's about 65% more than what we previously saw with the Alpha variant, which was already, 43 to 90% more. So this is, we think, at least double what the prior original strains were for contagiousness. And we saw that really take its toll in India. So India had really kind of escaped big surges or bad surges throughout most of the pandemic. They had kind of patted themselves on the back for, thinking they were doing everything right. And perhaps they were, perhaps some of it was unrecognized, but it really changed in March and April, and then taking off in May, in particular in India, where they had an explosion of cases there. And we had, some of these horrific scenes of outside crematoriums burning, all day and all night to try and handle the mounting dead bodies that rapidly exceeded their morgue and capacities. And interestingly, an antibody study was just done in the wake of all of this in India. Cases are on the decline there, but an antibody study was done on about 27,000 India residents from multiple areas around India. And they actually found about 67% of India residents had evidence of antibodies to the coronavirus. So that's a huge number. And I'll remember that number here because I'm going to get to sort of how that compares to where we are in the United States. But it rapidly swept through and apparently caused infection in almost 2/3 of the population of India in a very short period of time. And now it has become the predominant strain in the United States. The Delta variant is represented by the dark orange here. The lighter orange is the UK Alpha variant. And you can see that as of mid-July, 83% of the sequenced variants that are being tracked by the CDC are now Delta. And looking at that regionally, it varies from region to region, but we're not sampling a lot here in North Dakota, but around us, some of the states like Minnesota sampling quite a few. It's looking like well in the 90% range of variants that are sequenced are Delta. So it's here, it's spreading. If it's not the predominant strain now, it will be very, very shortly, and I think it probably already is. And this may be, in part, maybe in large part, responsible for the significant uptick in cases that are now being seen in multiple states. So this was just from a few days ago, looking at the cases and surges in different states, and you can see that in several of the southern states now, there's marked increases in the case counts, starting to get close to what was seen in their previous largest waves. That may be for a couple of reasons. I think the obvious reason may be because of Delta. It also may be like we saw last summer. During the summer, the southern states are very, very hot. We're seeing, very hot summer in most of the United States, and in the South, when it gets very, very hot, they tend to go indoors more, and sort of indoor congregating and air-conditioned air is maybe better at spreading the virus. So that might be part of the reason as well. Let me just focus on 3 of these states, because I think the other part of the explanation may have to do with vaccination rates. So if you look at what % of the total population is fully vaccinated, and we look at those 3 southern states, they are amongst the lowest in the country. The lighter green are the lowest states for vaccination rates, total population vaccinated in the country, and they're sitting around 34, 35, 36% of the total population vaccinated. North Dakota, we're a little better, but not a lot better. We're at 39.7%. Contrast that with some of the states right around us, like Minnesota and South Dakota, at 53 and a little over 46% of their total population fully vaccinated. What is this Delta variant doing in some of these southern states? So in Mississippi's sort of a good example. It's clear that Delta is causing the surge in cases there. It is now stressing and stretching several hospital systems. 13 hospitals reported that they had no ICU beds available as of about a little over a week ago, attributing that to the Delta variant spike. It's been noted that over 90% of Mississippi's COVID-19 cases are among unvaccinated people. That's certainly the trend around all the United States. Little warning about this, for future reference, as we get more and more and more vaccinated, you will see that number drop. You will see that cases may start to be higher in the vaccinated, the proportion may be higher in the vaccinated population. So imagine if we had 100% of North Dakota vaccinated and you had 3 breakthrough cases, you could say 100% of the cases are in vaccinated population, but of course it would be an extremely low number. So you have to look at what's called the base rate. If you're curious about that sort of thing, look up base rate fallacy to see how this is sometimes misinterpreted or misused. But right now, it is clearly a epidemic in the US of the unvaccinated. There was an editorial in the paper recently kind of looking at North Dakota and how we are trending like Mississippi, and that's not a good thing on a lot of healthcare measures. And with our vaccination rates being close to theirs, it may be a cautionary note for us here in North Dakota. So are the outcomes of Delta worse? What do we know about outcomes? And I think the answer is we don't know, but maybe. So there's some reason to think that it might be. A recent study that was just published online noted that when you swab the throat of people with Delta variant infection compared to prior variants, it's about 1,000 times more virus present in the oropharynx than in the earlier variants. That certainly would explain the increased contagiousness or increased transmissibility. Sometimes viral load can also be correlated strongly with virulence or how bad it may affect us. So there's reason to think, virologically, there's reasons to think why it might lead to worse outcomes. A study that was just published from Scotland that looked at their public health records and database showed that hospitalization rates with Delta went up 85%. So you were 85% more likely to be hospitalized with a Delta virus infection than an earlier variant infection. There may be some reasons for that to be a skewed data. If there's less testing, you may be testing the sicker people more. But I think there's reason to believe that at least there's a component of this that may be truly reflective that it can lead to higher hospitalization rates. And in fact, here in North Dakota, kind of looking at the same thing, this is in hospitalization rates in 20 to 29-year-olds. So young, healthy, often kind of people that think they're not at any risk from this. And hospitalization rates in that group were relatively low, about 0.5% at the highest early on 1%. But here in June, we're seeing significantly higher rates of hospitalization in that age group. And that may again be an artifact of testing, although I can't imagine it's that much different from our testing is that much different from March, April into May and June. Where we are now seeing a significantly higher proportion of those even young people landing in the hospital with infection, which I suspect is being driven by Delta. So we got several questions before the seminar on whether the vaccine would protect against the Delta variant. And here I think the news is for the most part pretty good. So when you look at the UK, that's been ahead of us in all of this, Delta started to appear in the orange here in late April, rapidly became the dominant strain in the UK and led to a resurgence or another wave in the UK. So it was causing a marked increase in cases there. However, if you look at their rolling average of cases and then deaths in their second wave, which was primarily the Alpha variant, compared to their third wave, which is by far predominantly the Delta variant, you can see as cases went up, and here the denominator is per 100,000 population, and their proportional deaths, this is per 10 million population, deaths went up proportional to the number of cases. And this is over time after, days after that variant was introduced into the population. Looking at the third wave here, you can see cases are going up, but we're not seeing that dramatic proportional rise in deaths, thankfully. And that's probably because the most at-risk population in the UK has been vaccinated, and they are one of the most vaccinated countries in the world right now. So, cases that are happening there are typically in the younger or the less vulnerable, and some breakthrough cases in people who are vaccinated and they don't get very sick from it. So at least as far as deaths, in our example in the UK, it has not led to a resurgence of mortality. This is a bit of a complicated graph, but it's worth staring at for a couple of seconds because this gets to what we know, which isn't great yet, but we're accumulating data, but what we know about vaccine effectiveness against the Delta variant. So we don't have really great data from the United States yet, but we have data from England, Scotland, Israel, and Canada. So on the left here is efficacy against symptomatic infection. Do I get any symptoms at all? And on the right is efficacy against more severe infection, hospitalizations. So let's look at the UK, England here. In there, when they had alpha is predominant. This is the Pfizer vaccine in blue. The solid line is full 2-dose vaccination. You can see they were 90–95% effective against symptomatic infection. With Delta, that dropped a little. It's still in the probably right around 90%. With their AstraZeneca vaccine, which is a lot like our Johnson & Johnson vaccine. We don't have AstraZeneca in the US, but we have Johnson & Johnson. They're very similar platforms. That was not as efficacious from the beginning, around 68, I think, % if I remember right. And that dropped down to about 60% against symptomatic infection. Scotland, pretty similar to England overall, like with the Pfizer vaccine. Israel has been a bit of an outlier here. Israel is reporting more significant drops. And there's a lot of debate in the sort of medical and public health community about how they're calculating that and how they're doing that, but they've reported a drop from, in the high 90s for effectiveness against symptomatic infection down to the 63–64% range. And they put out a more recent report, and these are news releases. These aren't actual published data, so we haven't had a chance to really look at how they're doing this and how they're calculating this. They're saying maybe even as low as 39% for protection against symptomatic infection. But again, they're an outlier. England, Scotland showing much better protection with Pfizer. Canada showing very little drop from alpha to delta. And even with one dose, you can see not huge amounts of drop. Some here with one dose protection, but then go over to the side with against severe infection, surrogate being hospitalization, and very little drop off at all. And so I think what we see from, the overall mortality rates in the UK and the overt looking at effectiveness in vaccinated population, the story is still very good against severe illness and deaths. One of the questions comes up that came to us beforehand is people who got the Johnson & Johnson vaccine, which is again a lot like this AstraZeneca vaccine, a little bit lower efficacy against symptomatic infection, but still very good, even with one dose here against the severe disease. We do not think at this point there's any need to recommend doing anything more if you've had the Johnson & Johnson vaccine. That may change as data rolls in, but at this point, we don't think people need to be overly concerned given the very high levels of protection with these types of vaccines against what really matters, hospitalization and death. So kind of summarizing that, we know that Delta spreads faster into more people. It does seem to be causing young people to be infected more and maybe more significant outcomes, worse outcomes in young people. It looks like it may be more likely to put you in the hospital. And I think a lot of experts are saying, and I tend to believe this myself, is that if you have not yet been infected or vaccinated, you're highly likely to be infected sometime in the next 3, 6, 12 months. These are, as we know, in the family of coronaviruses. Coronaviruses have been around us a long time. These are the viruses that cause the common cold. All of us have been infected. Essentially, all of us have been infected with one of these by the time we're 4 years old. These viruses transmit in the same way, but they're unfortunately much more dangerous. So there's no reason to think this is not going to continue to spread amongst all of us who have not either been infected before or been vaccinated. And then finishing with that is that the vaccines are still looking very protective, or particularly against severe disease. So a lot of people will talk about, mortality. Well, I'm young, I'm healthy, I'm not likely to die. So I already talked about hospitalization. Your hospitalization is much higher than the death rates. You're a lot more likely to land in the hospital from infection across all age groups. But I think we need to really be thinking hard about what we are seeing now with this long COVID. And it is literally every day a new publication is coming out in our medical literature on studies looking at the long-term effects of coronavirus infection. And it's troubling. So this was a study published in the Journal of American Medical Association, a summary of 45 studies out there, and found overall 73% of people, this was predominantly hospitalized people, not exclusively, but predominantly hospitalized people, had at least one or more symptoms at least 60 days out after their diagnosis. So 2 months out, the majority of people are still experiencing some kind of symptoms. Most commonly, fatigue, difficulty breathing, loss of memory, new diagnosis of anxiety or depression, persistent loss of taste and or smell. Now, I'm going to show you some data in a second here. Kind of take note of loss of memory, new diagnosis of anxiety or depression, persistent loss of taste or smell, and let me show you some other interesting data that may help explain some of that. But even if you had milder infection and were not hospitalized, this was a study looking at 6-month follow-up. This was a small group, so it's not a huge study, but these were outpatients with milder disease. And even in that 18 to 39-year-old age group, over 25% had one or more symptoms going out 6 months after their diagnosis. And that went up substantially as you got older, 30% in the 40 to 64-year-old age group, and over 40% in the over 65-year-old age group. This was another study just published looking at a big Italian cohort because they got their infection very early on. So now they have 1-year data on follow-up after their group of infected people. So this was a mix of hospitalized patients and outpatients. About 60%, I think, had been in the hospital, and about 40, if I'm remembering, about 40% had been outpatients. And here again, 1 year out, 69% had one or more symptoms. Again, most often fatigue, weakness. They reported sleep disorders, muscle and joint pain, cognitive problems, the ability to concentrate, think, memory, and respiratory problems like shortness of breath. These are substantial ongoing problems lingering months to maybe even a year or more out. In this study I found recently published, very fascinating. This was a study from the UK where they previously had been doing a long-term study looking at a variety of different things like brain structure in a group of British people from the UK. So they had all these background MRI scans of the brain on people. I think they're doing this yearly or every other year. And they said, hey, let's take a look at our group of people with all these serial brain scans and look at the ones that got COVID and compare them to the ones that didn't get COVID. So they matched them up by age and underlying medical health and underlying conditions. And they took a look and compared 394 COVID patients with 388 well-matched controls who had been getting these serial brain scans before and after the COVID epidemic. And what they found was very interesting and troubling. They found that the COVID-19 patients had significant shrinkage in the gray matter of their brain in 5 different areas of the brain. And those areas of the brain are those areas responsible for taste, smell, memory, and emotions. So when you see reports of increased anxiety disorders, increased depression, ongoing troubles with taste or smell, difficulty concentrating, and you have correlates of gray matter brain changes in the brain in people, and these, let me tell you, these were almost all outpatients, not severe disease, not hospitalized patients, but predominantly over 90%, 95% were outpatients with mild, to moderate disease, not requiring hospitalization. That's very troubling. And the New England Journal of Medicine just put out a perspectives piece, kind of, cautioning the healthcare systems to get ready for our next national, they're calling it health disaster, which is long haul COVID. That we are now seeing major health systems establishing dedicated clinics, multi-specialty clinics, to trying to treat and manage people with long-term problems and debility from their prior COVID infections. So, we are faced with choices here. And we are faced with like how to do the sort of calculus on this, how to choose. And what I've tried to show you is kind of what happens with when you choose to sort of take your chances with the virus. And again, I will reiterate, I think, if you have not been previously infected and you have not been previously vaccinated, it's likely for the majority of you, it's a matter of time that you will be exposed and probably infected with the coronavirus. Most people will do pretty well, but I've given you some of the data on what can happen versus what happens when you take the vaccine. So people are trying to weigh risks and benefits, right? So we need to know what are the risks of vaccine, and every drug we take and every vaccine we take has potential risks. So let's look at those. So this is actually already a little bit old. This is July 12th. We've got, I don't know, it's pretty close to, I think, 190 million people that have been vaccinated in the US now. And so that's a lot of people that we've been looking really hard at. I mean, these people are under a microscope with a number of different surveillance systems that are in place to understand safety and risk. We have traditional symptoms that we've had for a long time, and we have some new systems that have been put into place that we haven't used before. So we've put these under very intense scrutiny. Some people have heard about the VAERS, or Vaccine Adverse Reporting System. That's one of several different mechanisms, multiple different layers of monitoring that we do. And it's actually not the best one. It's useful as sort of an early warning system of detecting things. It doesn't tell us at all about what's the background rate of these problems. For that, you need a control group. And we have systems, for example, the Vaccine Safety Data Link that links large health systems, electronic databases to compare vaccinated people to unvaccinated people for any kind of question that we're looking at. And these are very robust, very useful systems for trying to understand risk. And so one of the important things we need to understand, whenever you hear somebody say, so many people died after the vaccine, or so many people had a stroke after the vaccine, or so many people had a heart attack after the vaccine, that always has to be contrasted with what's the background rate of those problems had they not gotten vaccinated. This is called a controlled trial. So that's why you hear, doctors and public health officials get most excited about when we have data from randomized controlled trials, or even non-randomized controlled trials, what we call epidemiologic studies. So what happens when you take 10 million Americans over, let's say, 2 months, if we gave them something completely benign, a sugar pill, and watched them? And by the way, at our peak, that's about how many people we were vaccinating a week, about 10 million people a week. So just take a given week of vaccinated people when we were vaccinating the most, like in February or so, and watch them for 2 months. This is what we would expect to see: 4,000 heart attacks, 1,700 blood clots, almost 4,000 strokes, almost 10,000 new diagnoses of cancer, and 14,000 deaths. So when somebody says, somebody died after the vaccine, or somebody got a stroke after the vaccine, or somebody got a blood clot after the vaccine, you kind of have to shrug your shoulders and say, okay, what does that mean when I know this many people are going to die or get a stroke or get a heart attack, regardless of what I give them, if I gave them nothing? And so we look at that, we do that, we try and compare this to background rates, we try to compare them to control groups, and what do we find? There are some things that have certainly shown up. Certainly we know that, like, the kind of well-reported side effects of the vaccine, like a sore arm or headache or muscle aches or low-grade fevers, those are fairly common. Those can occur in a quarter to sometimes the sore arm over half of people. They're short-lived. They tend to be fairly benign, lasting typically 1 to 2 days. What we're mostly concerned about, obviously, is the more serious adverse events and what has been identified by that intense scrutiny. There are some. Anaphylaxis in about 2 to 5 cases per million. The thrombosis and thrombocytopenia syndrome that's been reported with the J&J vaccine. This is that unusual clotting disorder that's been identified. Overall, it's about 3 out of 1 million people. It's highest in younger reproductive aged females. I'll get more into this in a second. Now we've been hearing about the Guillain-Barré syndrome, a type of autoimmune paralysis that can occur after the J&J vaccine. That's been about 8 cases per million. That's predominantly found in older males. And then myocarditis after the Pfizer or Moderna vaccines, the mRNA vaccines. Overall, that's about 3.5 per million in adults, about 25 per million in those under 30. And I'm going to get more into that because that's one of the highest rates of something that we see. So we'll take a little closer look at that. But this is what's been identified with intense scrutiny. So the first thing I'd point out from that is we're finding needles in haystacks. I mean, these are extraordinarily rare events, and our system is finding them and looking very hard. All of us doctors get multiple alerts from the CDC and our health departments to, like, look for these, report them, send them in. We need to know about any and all of these, and they may not capture everything, but they're capturing of serious adverse events. We know that a lot of these systems capture the majority. You sometimes hear they capture very low numbers. We're not very good at capturing the sore arms and the headaches and the muscle aches in these reporting systems, but we are pretty good at capturing the serious adverse events. So let's take a little closer look at one of these. Let's look at that myocarditis in males, which is the high-risk group. It's, for whatever reason, it seems to be much higher in males, and particularly young males. So this is actually a different published study. This estimates are on the high end of things. There are other estimates that are about half of this, but I chose the high end. So let's look at the highest estimates of risk of myocarditis, and particularly in males. And let me just focus for a second on the 18 to 24-year-old age group. So, because I'm at a university, we have a lot of college students. Let's focus on them because we have some interesting data that we can compare them to. So in that 18 to 24-year-old male group, it's about 45 to 56 cases of myocarditis, heart inflammation, per million doses given. And let me just point out, almost all of those have recovered well. It's not caused any permanent problems, has not led to hospitalization in the vast majority. But it's something of concern. Anybody with inflammation of the heart sounds kind of scary, right? So let's just kind of put it in the middle there. Let's say 50 per million cases 50 cases per million doses given. Let's compare that to some data that we just recently got from a published study on Big Ten athletes. So this is from the Big Ten conference. It's like more than 10 universities. They looked at 13 universities, and they did cardiac MRI imaging on athletes. So these are people in their prime of their health, in almost 1,600 athletes after they recovered from recent SARS-CoV-2 infection. So what did they find? So cardiac MRI is the most sensitive test for looking for inflammation in the heart. It's very sensitive. It's one of our best tests for looking for myocarditis or heart inflammation. They found that 2.3% of those athletes had evidence of heart inflammation from the virus. No, we're not talking about the vaccine here. We're talking about the virus. 2.3%. So let's just sort of put that in better numbers here. So our young man is trying to decide, should he take his chances with the virus or should he take his chances with the vaccine? Vaccine risk, if you kind of boil that down, he's got about a 1 out of 20,000 chance if he's in that 18 to 24-year-old age group. And again, that's on the high side. Other estimates put that more at 1 to 40,000, but I chose the high end, 1 out of 20,000 chance. That 2.3% translates in with the virus about a 1 out of 43 chance of having myocarditis. That's just one thing we're talking about, myocarditis. We didn't talk about long COVID. We didn't talk about hospitalization. We didn't talk about the very small risk of death. Those are all also things that this young man might have to contend with. So just even on the myocarditis thing alone, the risk of the vaccine or the risk of the virus greatly outweigh the risks of the vaccine on that one parameter alone. Kind of putting this all together, let's look at the risk in males in all the different age groups, 18 to 29, 30 to 49, 50 to 64, 65 plus. Here with the Johnson & Johnson vaccine, I'm showing this. Most of us haven't been vaccinated with that, but some have. We're giving out a lot more of the mRNA vaccines. But looking at the Guillain-Barré syndrome and the thrombosis and thrombocytopenia syndrome, it's these events are rare, except for like in more elderly males for the Guillain-Barré, about 14 to 17 per million doses. But you know, kind of looking here 2 to 3, 7 to 8, you know, kind of peaking with the Guillain-Barré out in this older male group with Johnson & Johnson. Contrast that with the risk of hospitalization and death based on recent numbers. So not our worst. This is based on recent numbers with hospitalization rates and deaths from starting about June 19th. So when we're much lower, what's the risk? So hospitalization and death, light blue is hospitalization, dark blue is death. I mean, it's vastly outweighed. The risk of hospitalization and death vastly outweigh these risks of Guillain-Barré or the TTP syndrome in all age groups. So let's flip over to the risk of myocarditis. This is now with the mRNA vaccines. And again, in that young male group, 18 to 29, it's a bit higher. These estimates are that from another data set that puts it a bit lower here at that 20 to 27 per million. Contrast that with hospitalization and death. I just showed you the myocarditis from it, so skipping that, let's look at hospitalization and death. Here again, significantly outweighed, even in that young, healthy group. You know, 300 hospitalizations prevented, you know, assuming 1 million people were exposed to the virus versus 1 million people exposed to the vaccine. Let's look at females, because the risks are a little bit different. Here, Guillain-Barré is very low risk, but the TTP, that thrombosis syndrome, is a little bit higher, especially in reproductive age females. Contrast that with hospitalization and death, it's vastly overshadowed. Again, vastly. Many more problems with hospitalization or death prevented than these conditions, which can be terrible, but for the most part, usually are reversible. They can be very serious though. Myocarditis in women, not very high risk. That has not shown to be a big problem. It's very rare, and here again, mRNA vaccines, prevention of hospitalization and death. This is how many cases would be prevented by that same group being vaccinated. Vastly overshadows these risks. So if all of this data seems a jumble, hard to kind of understand, I've been asking people to do a simple experiment of your own, just your own anecdotal observation. Data shows from a Pew survey around the country that 2 out of 3 Americans, 2/3 of us, know someone who's been hospitalized or died from COVID. And I'd ask you, think about it. Do you know someone who's been hospitalized or died from COVID? I do. These were public examples, so I'm not disclosing any health information. These were in the newspapers and well publicized on the news. Monsignor Jeffrey Wald was a dear friend of our family. He was my pastor for 12 years. He then moved to Jamestown, where he was the pastor of the Basilica there in Jamestown. Died at the age of 56 from COVID, and that was a significant loss to my family and my children who knew him very well. Dave Andall had been running for the state legislature. He grew up on a ranch about 2 miles from where I lived, northwest of Bismarck, where I grew up for part of my life. I babysat him and his sisters, and when I was in middle school. He's 55 years old when he died. Those were 2 people that I knew fairly well, and he was a friend of my brother's. These were publicized cases. So I'd ask again, who do you know? And then I'd ask you to think, and if you're one of those 1/3 of people who don't know anybody, you can probably go one step removed from yourself and think about somebody that you know, an acquaintance that you know, or you know someone or know someone. And I'd ask a similar question: who do you know that's been vaccinated? And do you know anyone that's been hospitalized or died of the vaccine? Personally, do you personally know anyone who's been hospitalized or died of the vaccine? And I will say there might be some urban legends out there that you've read, but in your personal experience of the people you know who've been vaccinated, how have they done? And just think about them. Now, another question that we've gotten a fair amount of is, I've already had COVID. I should be protected, right? Do I need the vaccine? And I think that's a fair question. That's a very reasonable question. And the answer is I think the simple answer is we don't really know for sure how well protected we are, but let me walk you through what we kind of do know. So this was a study that was recently published by the Cleveland Clinic, and they followed their healthcare workers, overall a fairly healthy group, probably working age people, over 5 months. Now this was pre-Delta, by the way, so we don't know what Delta does to this type of information. But over time, their unvaccinated workforce just got more and more and more infections until, over the study period, about 5% of them had become infected over that period of time. And they weren't looking for infections. This was just self-reported, like, hey, I tested positive, I can't work for the next 10 days. And then they looked at those who had been previously infected, not previously infected and vaccinated, and none of them got infection. But to be fair, they looked at their previously infected and unvaccinated, and none of them got infected over this 5-month span of time. So that looks pretty good for both groups, vaccinated and infected, relatively, presumably, young, healthy workforce, although, there's going to be a mix of risks in there. But for the most part, looks pretty good. This is a different study, larger, much larger. This was out of Denmark. They have a huge, public healthcare database that they can mine for this kind of data. And here they looked a little further out, 6 to 7 months. And this was how well protected someone was if they had previous infection. So what were the reinfection rates? And you can kind of see for people under the age of 65, pretty good. Not perfect though. About 20% of the 35 to 64-year-olds weren't protected. About 17% of the under 35s weren't protected from reinfection. That fell significantly in the over 65-year-old age group, down to 47%, or 53% weren't protected from their prior infection. So that's a little bit of a cautionary note there. Now, what percent of us have been infected? That's kind of a big question. We're actually looking to try and do a study on this in North Dakota to get a better answer of, how many of us have already had it and might be immune or protected. This is a collection of data from the National Institute of Health in collaboration with hospital systems and healthcare systems that draw blood around the country. And they're taking some of that serum and looking to see what percent of it have antibodies. This is anonymous. They're not, tracking individuals, so it's all anonymized. And what they found over time is that's really kind of went up starting in January. This is out to about May of this year. And overall, they found antibodies, and this is antibodies to the virus, not to the vaccine. And there is a way of distinguishing that. 22% of the US population has antibodies from prior infection as of May 2021. That's not homogeneous. It's kind of spotty. I started to enter this on a map because they have it by individual state. And you can kind of see, highest in the sort of central Midwest, 37% in Ohio, states right around us, kind of low in Minnesota and Montana, pretty high in South Dakota. For whatever reason, North Dakota is not included in these surveys. I don't know why. It's like one of the only states that's not included in these surveys. So it's a gray box when you look up North Dakota. So we don't know where we're at. I would estimate we're probably close to South Dakota because we ran sort of neck and neck with them with hospitalizations and deaths. They exceeded us by a bit. So I would estimate that we're a little below this. I would estimate we're in the high 20% range, 27, 28, 29, something like that, but don't know for sure. But that's kind of what we're looking at. So when you're trying to figure out, are we at herd immunity? Well, by natural infection, we're nowhere close. By adding vaccines on top of that, you have to kind of figure out what percent of the vaccinated population overlaps this population that had prior infection. And I think, at best, we're maybe looking at, 50, 60+ % of us have some form of immunity either through vaccination or prior infection. So that leaves a lot of people still out there susceptible to the virus. So, should I get vaccinated if I've had prior infection? I think it's a reasonable question to ask. A couple points I would make why I would advocate for getting the vaccine. One, there doesn't seem to be a downside. There doesn't seem to be any increased risk or harm. And then a few other things. We do know from some studies on immune function, these are now test tube studies, so these aren't clinical studies. So these aren't as good as like a clinical study. We'd like to see the clinical data, but let's look at the test tube. People who had minimal to no symptoms from their infection, so the people who really kind of got by without getting very sick, make much less antibodies than people who were sicker, and they fade quicker. Up to 40% in one study lost their antibodies even by a couple months out if they had no real significant symptoms. So are they protected? Don't know. I'd be a little nervous if I was one of those. I tested positive, but I had no symptoms at all, or very minimal symptoms. Am I protected? I'd question that. We know from a study that was looked at with the Moderna vaccine that vaccinated people in that study made about 10-fold higher antibodies than those with prior infection. Typically, higher antibody levels typically predict better protection and lasting longer. Now, this is a test tube study. It's not a clinical study, so I can't say that certainly, but it looks suggestive. And then a couple of other studies looked at antibodies from the vaccine and compared those with antibodies from prior natural infection in the test tube against variants. So they looked at the Alpha variant, the UK, they looked at the P1 variant from Brazil, they looked at the variant from South Africa, and they did not look at Delta. I have not seen any data on Delta, so I can't answer this. But with these other variants, the antibodies were better. The vaccine-induced antibodies were better at neutralizing those variant viruses than the antibodies from people who had prior infection. So we have some evidence to think that vaccine-induced immunity may be better. I've read some things now in the news, and people posting, natural infection is better. We don't have any evidence of that, and I'd say at least in the test tube, or what we call in vitro, or in the test tube, suggests the opposite. But this question remains to be answered. We get several questions about children. I think we need to see the data of the vaccine trials that are being done in children under the age of 12. We've got moderately good data on children, aged 12 to 18. I don't have time to do, we could do a whole talk on this, but just a few points I would make. We have had now over 4 million cases in the US in children. It is absolutely true that they do much, much better than adults and fare better. But we have reports of 16,000 hospitalizations in children. That's only from 23 states that report on this. So I suspect that number is a fair amount higher, maybe double, given that we only got less than half the states reporting. There have been almost 4,200 cases of the multi-system inflammatory syndrome in children. This is a pretty serious illness that really can lay a kid out and put them in the hospital, make them very sick. It can affect the heart, it can affect a number of joints and so on. It's not well understood, but pretty hard to see when your kid gets this. And there have been almost 350 deaths from 43 states that are reporting on this. So these are much, much lower than other age groups, but they're not inconsequential. I also would say that we really don't know what's the prevalence, incidence and prevalence of long COVID in kids. There are increasing reports of this, of children with lingering ongoing problems after COVID. Lots of research and research dollars being put into looking at this right now, and how significant a problem is this? What might we expect? But I think this is a question mark out there that we have to weigh when we're worried about, what's the vaccine risk. We need to worry about what's the long-term virus risks, even to our children. And then if you haven't read about this outbreak in this gymnastics facility, you should be aware of it, because this might be a little hint of things to come for us as we get back to school. So this was an outbreak reported of Delta variant in an Oklahoma gymnastics facility during a gymnastics meet, I believe. And in that facility, an infected child came into the facility and spread it to 26 other gymnasts and staff members in that facility. Those people then brought it home to another 21 cases of their household contacts. The attack rate was 20% in that gymnastics facility. In other words, 20% of the exposed people got infection, which is pretty high compared to other outbreaks we've seen in earlier variants. The attack rate in households was 53%, which is a lot higher than what we've seen in earlier reports of secondary transmission in the household. When you looked at the cases by vaccination status, 85% of the cases were unvaccinated. 6% or 3 of the people were partially vaccinated. 4 people were fully vaccinated. So this points out vaccine isn't perfect, pretty darn good. The vast majority of the people that got it weren't vaccinated, but it can break through, and this is part of the reason why we need more of us vaccinated to kind of protect those, handful of people that don't seem to get full protection. And 2 of these people ended up in the hospital, 1 requiring the ICU. And bear in mind that a majority of the people in that facility were children. 63% were too young to be eligible for vaccines. That means they were under the age of 12. So, if it was more adults, you might have expected, potentially more hospitalizations and so on. So it was predominantly exposures in children. So this high attack rate, this rapid spread in a facility with a largely unvaccinated population of kids going back to school, I think we're going to be seeing these flares. Hopefully, our kids do well, as for the most part they have in the past, but we're going to be preparing ourselves for how to contend with flares and outbreaks again in our kids as they congregate. And then, as you saw in that outbreak, they brought it home to their household contacts, to their circle of loved ones, and we all have connections to someone who's at risk from COVID. So if we're not that worried about ourselves, who in your family might be at risk? I mean, we all have grandparents. We often have family members who are immunocompromised or have health conditions that put them at much higher risk. And we know that up to 10% by some of those studies aren't protected even from severe illness. So 90% protection is great. 10%, people that may be at risk for hospitalization or even, death, who in our family is among that 10%? And we don't know until it strikes or happens. So again, we have that ability to choose, but what I've tried to show you is that the benefits of vaccination vastly in all of us in the kind of the healthcare profession and public health, see this as vastly outweighing the risks, the benefits of, not getting vaccinated and taking your chances with the virus. And that's why you see, an AMA poll, American Medical Association poll, showing 96% of doctors are vaccinated. I mean, they see the value of this and jump to the front of the line when they were able. So I'll just finish with, I hope this helps you in some of your deliberations and your own kind of balancing and weighing risks and benefits. If you are now a little more ready to kind of, you've been, there was a lot of people, I think, understandably watching from the sidelines, kind of sitting on the fence, wanted to see how things played out. We've got a lot of data now to see how things are playing out. And I've tried to share a portion of that with you today. If this helps you with that, decision to maybe move towards vaccination, you can find a place, lots of health systems are doing this now, lots of pharmacies are doing this now. Public health clinics are doing this. Shouldn't be that hard for you to find a place to get a vaccine. If you aren't certain, you can go to vaccines.gov and find a place near you. So I'm, with 5 minutes left, Molly, I know there's the ability of some people to have asked questions. It looks like maybe you've handled a number of those, but anything you want me to try and address?
Yeah, sure. Thank you, Dr. Carson.
Yeah.
I think you addressed a lot of the questions that we received prior to the webinar today, but one thing I was wondering if you could touch on is, I think people do hear a lot about these breakthrough infections, or people who got vaccinated and they're still getting COVID, or they're hospitalized or have died. Can you touch more on maybe why that's happening?
Yeah.
And then also, can you get COVID from the vaccine? Are these people getting COVID from the COVID vaccine?
So the last one's very easy. It's not possible to get COVID from the vaccine. It's not a virus. It's one little bit of material genetic in the mRNA vaccines that makes one tiny piece of the virus, not anywhere near enough of the components of the virus to cause an infection. So it helps us train our immune system to recognize that one tiny piece of the virus when we are confronted with it. So it's physically impossible for it to cause infection. We have no vaccines in the country that are the whole virus, either killed or inactivated. We don't have any vaccines like that. There are vaccines for other infections that are like that. We don't have any vaccines like that for COVID. To the question about hearing about people who've had breakthrough infections, I guarantee you are going to know people that have breakthroughs over time, because as you vaccinate more and more and more people, the infections that do occur are going to be increasingly proportional in the vaccinated. But what you have to ask is, what's the attack rate? How many people in that vaccinated group are infected compared to how many people in the unvaccinated group are infected? Every time you look at that, it's vastly more in the unvaccinated group will get infected than in the vaccinated group. And if you just think about this, if we have 5 to 10% of people that aren't protected from the vaccine, that's from the clinical trials, just let's take 10%. If I have 200 million people vaccinated, which is what we're approaching here soon, if I have 200 million people vaccinated, that means 20 million people didn't get full protection or didn't get the benefit of protection from the vaccine. They're at the same risk as the unvaccinated group. But 180 million people did get protection. So when you have 20 million people who have equal susceptibility to the unvaccinated population, yeah, you're going to hear about these reports. You're going to hear about breakthroughs. Interestingly, overwhelmingly, those breakthroughs have been in the elderly and in people who have immunosuppressive conditions. So I saw a recent report that it was about half of the breakthroughs, that especially the ones that were landing people in the hospital and more serious, have conditions that make them a little less likely to respond well to the vaccine. Maybe don't have as good of an immune system.
And I think that explains the other question. I think we often hear from people who haven't yet been vaccinated, well, if you're vaccinated, why do you care if I'm vaccinated or not? And so that is kind of the concern, is that those of us who are vaccinated, not all of us are 100% protected against COVID, especially our elderly and immunocompromised may not be protected. And that's why we have to kind of put a bubble around them by all of us getting vaccinated.
Exactly.
You touched a little bit on how much more contagious Delta is. Do you want to add anything to that? I know some people are talking about what the R0 is of Delta versus previous strains. Can you kind of explain what that means?
Yeah. So, R0 is a term epidemiologists use. It's called the reproductive number. It's a measure of contagiousness, and what it measures is in a homogeneous population. So what this would typically mean, R0, the basic R0 is in like an unvaccinated population, where everybody's more or less equally susceptible. When you bring a person into that population, how many new cases will they typically spread it to? How many new people will they give it to? The estimates for the original coronavirus were, it was quite variable, but it typically landed somewhere around 2.5 to maybe 3.5. I looked to see if there's any good published data on the Delta variant on this, where they've actually done some of the studies. I haven't found that, but I've seen some pretty smart people in this area estimating it to be around 6, maybe a little higher. Again, getting to probably about twice as contagious as the earlier strains.
All right, and we do have a question, it looks like, about guidance on mask wearing for North Dakota residents, vaccinated or unvaccinated. Now, I know this afternoon, CDC is going to be coming out with, it sounds like, updated guidance on mask wearing. But did you have any comments on mask wearing as of how it stands right now for vaccinated versus unvaccinated individuals?
I was sort of hoping to avoid mask questions because you're just sort of guaranteed to make, some segment of the population upset one way or the other. I think I was glad to see mask requirements falling, and going away for vaccinated people. I think we need to get ourselves back to more and more of a semblance of normal as we are vaccinated. I think the Delta variant is gonna challenge us a bit here because we have a lot of people that aren't vaccinated yet. We don't like the idea of asking people, show us your vaccination status and prove that. I mean, that doesn't go too far or go very well. My suspicion will be I'm going to punt that mostly to what the CDC recommends, and I'll probably take the party line of whatever the CDC recommends. I'll probably recommend. My suspicion is that they will recommend that vaccinated people can still forego mask wearing unless the prevalence, and they'll probably set it at some level, is at a certain level in your community, in your city or your state or whatever, that if you're having X number of cases per 100,000 population or whatever, that you consider re-implementing mask guidelines. I suspect that's where they'll go, but I don't know. And I would just say let's wait and see.
And I should recommend too that right now, if you're immunocompromised and concerned about potentially the vaccine not working well, you may want to consider masking and avoiding large gatherings, especially gatherings when there's a high number of people unvaccinated, or your loved ones may want to mask around you. So that might be something you want to consider if you're immunocompromised. We didn't really touch on this, but we often get asked about, I know you showed hospitalizations, long haul COVID, other things to consider, but as far as death goes, I think some people think COVID deaths were somehow inflated in North Dakota or in the United States. Can you just talk about what the data is out there regarding COVID and deaths?
Yeah. So, to the people who kind of think, doctors are sort of wantonly slapping COVID labels on people who are dying, I would just say take a look at the data that's been tracked for years and years and years on weekly mortality by the CDC. If you Google CDC excess mortality, they've been trending for many years. What's the number of reported deaths from anything? So forget a COVID label, just forget somebody having a COVID label on their death certificate, and look at the CDC data on deaths from anything from 2015 through 2019 compared to 2020. For every week of the year starting in March, there were at the lowest 10% more deaths to the highest about 70% more deaths every week of the year throughout 2020 and going into 2021. It's now fallen. Thank God, it's fallen back to prior 2015 and 2019 trends. So my question to people who are kind of doubting that is, what was causing all those extra deaths? If you think it's like loneliness or lockdowns or whatever, okay, maybe. But the obvious answer is COVID. And when you look at those extra deaths, the vast majority of them had a COVID diagnosis attached to it. But if you even remove that, we have to explain why there was 30, 40, 50, 60, 70% more deaths week on week on week throughout 2020 compared to our prior 5 years. What was doing that?
And then I think we just have time for probably one more question. I think something that comes up from people who haven't yet chosen vaccination is, there's just going to be more variants coming. We're going to need booster doses. We don't know what the effectiveness of the vaccine is going to be against future variants. Can you kind of talk about why people should maybe consider vaccination, knowing that there likely will be variants in the future?
Sure. So, I have a few thoughts on that. So one is, we need to contend with the immediate problem at hand. We have an immediate kind of threat to our unvaccinated population. And yeah, we might be, theoretically, we might be kicking a can down the road a bit, but there is value in trying to have some immediate improved protection against all these kind of bad outcomes that we're seeing. But so far, the news, I think, is looking pretty good that we may not need any booster, or we may not need it for several years. There's now a couple of good studies that looked at memory cells, memory immune cells in the bone marrow and in our lymph nodes. Looks pretty good with the current vaccines inducing the type of cells we like to see for long-term immunity. The other reason if we can get, most everyone vaccinated so that the spread is way down, the virus doesn't have a chance to mutate into new variants. We actively intervene in its evolutionary process in trying to escape us. Third, I would say, even if we have partial protection, so I mean, these vaccines have been amongst the very best of any vaccines we have. We have vaccines that are that we take that aren't nearly this good, but they give us partial protection. Even if we have partial protection and variants can break through more easily, it's less likely that they will make us real sick. And when we get exposed to those variants, then we'll have, that sort of charges our immune system again. You get exposed, you get a little, hopefully mild infection, you're all the more able to fend off the next exposure and the next variant. So it's sort of mounting layers of protection, and I think the news is good. It may change. It may turn out that one of these escapes current vaccine-induced immunity and we need some kind of a booster. And we'll cross that bridge when we come to it. Right now, I don't think the evidence is looking very strong that that's necessary yet.
All right, well, thank you, Dr. Carson, for your presentation today. I hope it gave everybody something to think about when you're weighing your decision regarding to get COVID vaccine or risk getting COVID illness. But if you do have additional questions about COVID vaccination or COVID illness, you're encouraged to talk with a trusted healthcare provider. Contact your healthcare provider and get your questions answered about COVID-19 and vaccination. Otherwise, I just want to thank everyone for attending today, and this webinar will be posted on our Facebook page and website for viewing at a later date. So thank you, Dr. Carson, and thank you, everyone.
Thanks for having me.